So, by definition, environmental emergencies are medical conditions caused or worsened by weather, terrain, or unique atmospheric condition at high altitude or underwater. So, anything that has an outside influence that has to do with the environment is what would be an environmental emergency. Alright, so the things that we're going to look at today is going to be injury from temperature extremes, hypothermias. We're going to look at diving emergencies, not like diving from a diving board, but actual like underwater deep pressure diving stuff. And then also there's a little section on snake bites and toxicology with that stuff. Did y'all go over like venomous stuff in toxicology with Brandy the other day? Yeah, so a lot of that will be redundant, so we won't spend a lot of time with that. Alright? So, from 1999 to 2002, 4,607 people in the United States died of hypothermia-related causes. Exposure to extreme heat caused 3,442 deaths between 1999 and 2003. And then in the summer of 2003 alone, a heat wave in Europe caused as many as 70,000 deaths. So your common risk factors that would predispose people to environmental emergencies: age. Younger and older people. Younger people have immaturely developed thermoregulatory systems. And then older people, they start having degeneration of their thermoregulatory systems. Also, older people, they have breakdown of the barriers around them as well. Also, certain diseases, diabetes, cardiac diseases, things like that. Dehydration, often a common part of hyperthermia, but you can also have dehydration in hypothermia as well. You can have dehydration in any situation if they're not getting hydration, right? Age, gender, and then medical conditions, and also medications. So your body, how does it maintain body temperature? There are several processes that balance the supply and demand for the body's needs through metabolism. Thermoregulation is part of the homeostatic balance of the body. Occurs in the hypothalamus, and it balances heat production and dissipation. Now, whenever you have head injuries, especially head injuries where you start seeing posturing and things like that, you are concerned about what? Thermodynamics, right? You start worrying about hypothermia, you want to keep them warm. Also, on the opposite, you could be worried about hyperthermia as well. So your normal CBT, or your core body temperature, is 98.6. Starting temperature for hypothermia is 95 degrees, and for heat stroke is above 104. So your core body temperature is going to be the temperature of the core of the body, your heart, lungs, brain, and abdominal viscera. So that's why you can have cold extremities, shunted off extremities, pale, cool, clammy skin, but still have functioning organs, because it shunts the heat, the blood, back into the core. So the core is what we're looking at when we're looking at temperature. There are differences in the means in which you take a body temperature. Oral temperature is your general is your general temperature assessment, and axillary is usually about 1 degree cooler. So on like kids, if you do an axillary temp and it shows 97.6, then in reality their core temp is about 98.6. And then a rectal temp is usually about 1 degree hotter. All right. I know that we don't do them in this area here. My friend works over at Fort Benning, and heat emergencies is a big deal for them. Especially you get a lot of recruits that are from North, Wisconsin, Minnesota, New York, upstate New York, all those areas, and then they just throw them into the Georgia humidity in the middle of the summer, and they go through basic training, and they're not used to it. They have to do a core body temperature on every patient they pick up. How do you think they do it? Every patient they pick up during the summer. Now, I don't know if that goes all winter long, all season long, but I do know that in the summertime they have to do a core body temperature because, a lot of the military stuff, they will manage that stuff out in the field, right? So they ain't afraid, they ain't scared. We talked about the hypothalamus as your main thermoregulatory system. At rest, the body produces heat by metabolism. Whenever we start getting fever, we go into hypermetabolism. The body is working harder, so the byproduct is heat, right? Byproduct of metabolism is ATP and heat. So at rest, it produces heat by the metabolism of nutrients and liberation of water and carbon dioxide. Your basal metabolic rate should be in proportion to your normal body metabolic reactions. All right. So just normally, if we're just having metabolism while we're just resting, we should be able to keep a core temp of 98.6. When we're sick and the body is working in overdrive, then our core temp is going to go up because we're having higher metabolism. Heat loss in the environment increases as ratio of body surface area to body volume increases. And then heat generated by metabolism and glycogen breakdown warms the body. So your skin is one of your big organs that plays a major role in thermoregulation as well. So thermolysis is the release of stored heat and energy of the body. Several different things can increase the core body temperature. When it does, it causes vasodilation and sweating. The body can be cooled by different mechanisms, radiation, conduction, convection, and evaporation. Most often, our body's natural way to cool is through what? Evaporation, right? What happens? We sweat and the sweat dries, right? So you get your heat illnesses because you're exposed to an environment and the core body temperature goes up and there's not enough breakdown of that heat. There's not enough ridding of the body of that heat. Older people are a particular risk for heat illnesses. They don't sweat as much. It takes them a little while longer to acclimatize. They don't feel as thirsty. And they can't get out of the situations. And then, of course, infants and young children are more vulnerable too. They have higher metabolic heat production, and their core body temperature rises quicker during dehydration. Talked about military recruits and athletes. Other medications can affect thermoregulation. Diuretics, an older person that's on diuretics, or even a young person that's on diuretics, they're constantly ridding themselves of fluids. So it's harder for them to keep their electrolytes in balance, and it's hard for them to keep their fluids in balance as well. Beta blockers. They slow the tachycardic response to heat stress. Somebody's on a beta blocker, they start getting stressed, their heart won't pump as quick because they're on a beta blocker, and so the heart can't get blood to the rest of the body to perfuse it the way it should. All right, so our heat-related illnesses, our mildest is going to be your heat cramps. Cramping of the muscles, often due to sodium loss. Usually starts during strenuous activity, especially if somebody's not used to strenuous activity or if somebody has not hydrated. It says your management is to eliminate exposure, so get them cooled off, and to restore lost salt and water. If no nausea, give 1 or 2 glasses of salt-containing solution. What would that be? Huh? Well, you could, yep. IV, you could give normal saline. What about just like your energy, not your energy drinks, your Gatorades and your Powerades? They have a very high sodium content in them. Then if nauseated, just give it by saline, give saline by IV. If they're not nauseated, we're going to let them drink, but I would probably go ahead and start some IV fluids on them too as well. Now, here's the problem in the South. You've got to keep a close eye on your fluids. You either got to keep them in a cooler or you need to keep them inside of your station while you're not on the ambulance, because it gets, 10, 20 degrees hotter inside of an automobile than what it is outside. So you're going to further increase the heat-related illness if you give them hot fluids. All right? Heat syncope. Somebody has a syncopal episode under heat stress. You would treat it just like you would any other heat-related illness, except you're going to pay closer attention to see if the syncope is caused by heat or if it's caused by something else, and then replace fluid. Heat exhaustion. This is a milder form. Definitely start seeing this with volume depletion and heat stress. You've got water-depleted heat exhaustion and sodium-depleted heat exhaustion, and they could go hand in hand. Now, with heat exhaustion, you may have exercise-associated hyponatremia. This is where drinking water alone could hurt somebody when they're outside sweating. All right? Because water does help you hydrate, but you're not just losing fluids when you're sweating. What else are you losing? Electrolytes. So you do need electrolyte replacement as well. So this is where they could actually become water toxic. If you suspect exercise-associated hyponatremia, don't let them drink anymore. Give them normal saline or a hypertonic solution. In our case, it's more than likely going to be normal saline. If temperature is elevated, tepid water, all right? So with all these, we don't want to just douse them. We don't want to do the cold water challenge with these patients, right? We want to tepid water, even get a sheet and soak it with tepid water and put it over them, all right? Then heat stroke, most deadly of them. The body's temp goes way above 104, altered mental status, consequence of related effects of elevated temperatures of the cells. You've got 2 heat stroke syndromes, classic and exertional. Your assessment, altered mental status, hallucination. Now, why do you think hallucinations may be a factor in this? Low sodium. Somebody with low sodium can start having some severe altered mental status issues. You'll have dry, red, hot skin, which is a classic heat stroke. So you always hear somebody, or you may not always hear, but somebody starts getting worried when you stop sweating and you're 100-degree temperature, right? And then pale and sweaty skin, that's going to be exertional heat stroke, where you, classic heat stroke is where you've just been volume depleted, you've been out in the sun. Exertional heat stroke is where you've done too much, too fast out in the sun, out in the heat. Then there's other conditions that may mimic heat stroke that you can see right here. Management, cool as rapidly as possible. Now this is heat stroke. IV, cool fluids, monitor cardiac rhythm. What are we looking for? Yeah, hyperkalemia, right? And prepare to treat for seizures as well. Amen. Seizures, you're going to see seizures with this because why? The brain cells can't stand the heat, right? All right? So prevention of heat illness. Now this is something on the flip side that we need to be paying attention to as well. It's very easy to get too hot and exert yourself on the ambulance. Especially if you've just been laid up in a recliner watching the news or watching TV all day long, and then you've got a big car wreck out on the interstate at 3 o'clock in the afternoon. All right? People that are out in the heat a lot, they grow a little bit more used to it. But if you're not, you've got to acclimate to the environment. Maintain personal fitness. Eat good. Drink good. And again, remember, if you're out for prolonged times, don't just drink water. Water is good for hydration, but you also do need electrolyte replacement. All right? Kind of my rule of thumb is I'll drink a bottle of water, I'll drink a bottle of Gatorade. You know, a cup of water, a cup of Gatorade. All right? Local cold injuries, frostbite. Frostbite, the cells become ischemic. Kind of the same processes of gangrene in the fact that the cells become ischemic, then they become necrotic. Frostnip is a mild form of frostbite. With frostbite, do we massage or manipulate the area? No. Why? Right, because the cells are literally frozen, right? So if we start manipulating it, we could break off those crystals and they could do damage. They could get into the bloodstream or what have you. So obviously cold exposure, exposure to the extremities, fatigue, dehydration, hunger. So again, dehydration is not going to be just in heat. It's also going to be in cold as well. The problem with cold is that you can't really tell that you're getting thirsty or that you're getting dehydrated. In the heat, you can tell because you're losing a lot of sweat, you're losing a lot of fluids, all right? Just a couple of pictures of the superficial frostbite. So it's usually going to be at the tips of the fingers and all that. A lot of times you may see blistering or swelling, redness. The deep frostbite is where you get like, was the movie Mr. Deeds, where his foot was frostbitten and he stabbed him. Yeah. And so this tissue is necrotic now, so there's really not a lot of help or hope for this tissue. It's very important that you determine the depth of the injury. Very important that you figure out, is it just a superficial localized or is it a deep? Reperfusion injury can be excruciating. What does it mean by reperfusion? Yeah, it starts getting warmed up and then blood starts flowing into it again. So typically they're not going to really hurt a whole lot at first, but then you start getting blood flowing back. You know, what's left of the nerve endings and stuff is you're going to start getting that neuro sensation. And then treatment is determined by distance to the hospital and if partially or completely thaw, all right? Any questions so far? So with your cold injury, most of the time it's going to include areas that are exposed. So that would be your nose, your ears, your fingers, all right? Now, well, we'll get to that in just a minute. So your general principles of managing these patients. Number one, get them from the environment, right? Remove any wet, cold clothing. try to start passively rewarming them. Don't massage or rub the area. We explain why. Give pain medication. Again, because once we start getting them warmed up, they're going to start hurting. Cover blisters with dry, sterile dressings. And then consider rewarming if no potential of refreezing. What does that mean? They're not going to freeze again. We've got them out of that environment. They're on the back of our warm ambulance. So with your warming, if medical control says, all right, go ahead, and again, this isn't going to be something that we're going to face a whole lot. Now, I know there was some issues this past year, back in the wintertime. There was, I know of one case where a guy had cardiac arrest and he was out in the cold. I think one of my AMT students worked it, and his core body temperature was way, way low, and they kept getting things back on him, but they couldn't pronounce him dead or anything until he was actually warmed back to core temperature. Your goal is temperature between 98 and 100 degrees. A water bath. Ensure immersion without touching the container. Alright, so this is going to be more like, if you've got just a localized hand injury or something, you could put it in a warm water. They don't need to touch the sides or anything like that. Alright? Trenchfoot. Who sees Trenchfoot often? The military. Trenchfoot was a big deal. I think back in Vietnam, a lot of folks had issue with that. And it's not necessarily just a freezing type injury. It's where their feet are exposed to cool, wet conditions continuously. So their boots and stuff will get wet. And then there's this other thing that you see with this called chillblains, which are itchy reddish purple lesions on the face or extremities. Wet feet lose heat 25 times faster than dry feet. And then vasoconstriction and an ischemic cascade is similar to that of frostbite, and that's what actually causes the injury. This chillblains is believed to represent longer exposure to temperatures just above freezing. And again, when you transport, you want to have the ambulance a little bit warm. But again, you don't want to have it like 90 degrees in there. You just want to try to get their temperature back a little bit at a time. On the flip side, we talk about the Dr. Cool deal with like the cardiac hypothermia and all that. The body is not used to it, and that's why you have environmental issues when there's a rapid decline or rapid increase in body temperature. So when we try to cool these patients off, we bring it down real slowly, okay? So if somebody's like has a heat stroke, we want to get their temperature down below where they're out of danger, all right? But like if it's like heat exhaustion, whatever, we want to cool them down, but we may not want to just get them down to 95 degrees really quickly, all right? Does that make sense? Hypothermia. Below 95 degrees of your core body temp. Sometimes the actual symptoms may start earlier than they hit 95 degrees. Issues with this is inadequate thermogenesis. So inadequate production of heat. The environment is too much that the body can't keep up with it to keep itself warm. And then, of course, the body, just like with everything else, has compensatory mechanisms. They try to increase rewarming, decrease heat breakdown and heat loss, and then adaptive behavioral changes as well. With hypothermia, alcohol is the most common cause of heat loss in urban settings. What do you think happens? Folks get drunk and they pass out in the environment, right? Also, alcohol hinders the body's attempt to insulate the warm core. It impairs shivering. Shivering is part of thermogenesis, right? Shivering is the body's way of trying to create heat. And then we talked about earlier, metabolism and the breakdown of glycogen is also what creates heat. Alcoholics often won't have good glycogen stores. Then other risk factors are the folks that are taking tricyclic antidepressants, sedative medications, and phenothiazines. Like we talked about, ensure that the ambulance is preheated when we get them on. We don't want to get them onto a cold environment. The National Institute of Health focuses on umbles in early stages. So these are early stages of hypothermia. Stumbles, mumbles, fumbles, grumbles. All right? Start seeing some of this. These are indicators of how cold affects the cerebral and cognitive functionings of the body. So, the American Heart actually has a little hand in defining hypothermia as well. Mild hypothermia, greater than 93.2. Moderate's 86 to 93.2, and severe is 86 degrees. Then, of course, you've got different classifications of hypothermia. So what is important for us to remember about cardiac arrest and hypothermia? We can't give up on that patient if they are hypothermic, right? Usually in early stages, if the core body temperature is more than 95% or 95 degrees, they may start showing obvious symptoms, but the body still is trying to compensate through thermogenesis. The classifications of hypothermia is the acute, subacute, and chronic is time of onset. The acute obviously is going to be rapidly. Cold water immersion, getting into the cold water. Subacute over a short period of time, and then chronic is going to affect those that are like homeless that over longer periods of time. Then your primary and your secondary is caused, primary is caused by cold exposures, and then your secondary hypothermia may not be environmental at all. It may be caused by inadequate thermoregulation in the body and symptoms such as sepsis, or even maybe head injuries and things like that where the hypothalamus is impaired. So with hypothermia, signs and symptoms. A lot of your neurosigns and symptoms may mimic stroke, head injury, being intoxicated. And then changes in the cardiovascular system. What happens when you have an increase in blood viscosity? All right, cardiac output goes down because the blood's not moving as quick, right? It's thicker. So it takes more work, more energy to pump thicker fluid. Because of that, it may lead to a hypovolemic state because, again, cardiac output's going down.
Was that saying that hypothermia caused that, or that was a cause of that makes a lot of sense?
Where?
The changes in cardiovascular system lead to...
It's going to be an effect of hypothermia.
So the changes are caused by hypothermia?
Yeah.
Okay.
Yeah. Mm-hmm. So AHA in 2010, when they changed their guidelines, they suggest attempting defibrillation once. If it continues to go on, then it may be a direct result of the hypothermia, and just like treatment of other things, you've got to get down to the reason why, the reversible cause. It's one of your H's and T's. Hypothermia is one of your H's, right? So you've got to get them warmed back up in order for them to get out of this dysrhythmia. All right? Your muscle system, your initial reaction is shivering. Shivering stops around 91 degrees, and the body just becomes worn out. It's not being able to create metabolism and to create heat. Shivering also depletes the body's ATP stores and glucose stores. All right? So really, truly, shivering is a good thing for a short time to keep you warm, but it further depletes your body of the things it needs to keep you going. So obviously with hypothermia cares is aimed at preventing heat loss, rewarming. If you've got patients that are breathing with a pulse, mild hypothermia, you do the passive rewarming. That's what I was talking about. You don't want to just get them go from just one extreme to another very quickly. With severe hypothermia, less than 86, they're going to require an active core rewarming process that's in the hospital, but we can start that cascade with heat packs and things like that. All right. Patients with no pulse or breathing, CPR, rapid identification. We're going to do our ACLS stuff, but again, they just say one defibrillation attempt. Just if one of us fell out of cardiac arrest and VPAC, we would shock, right? But a cold person, shock him once, they're probably in VPAC or VFib because of the hypothermia, so we need to get them warmed back up. If there's other factors, lethal traumatic injuries, they're solidly frozen, like, you know, these folks that might have been out in the cold for a very, very long time, you know, they're dead. They're dead. We're not going to try to rewarm them. They're dead. All right? Y'all good? You want to keep going? All right. Drowning. Drowning. And I'm going to spend a lot of time on this. Drowning, respiratory impairment due to submersion, right? There's a couple of things that go into drowning. There's wet drownings and there's dry drownings. What is the difference in the two?
One's in a liquid, one's in the lungs, like as far as...
All right. Everybody at one time, shout out your answers. So you can have a wet drowning and a dry drowning submerged in water. All right. So it was kind of, what did you say?
I think mine's wrong now. Lack of air versus air in lungs.
That's right. So there's this drowning continuum. When you go under, body's natural response is to hold its breath, right? The next second natural response is to laryngospasm. Shuts off. So fluid, or water, may not ever get into the lungs because the larynx has spasmed down to the point to where it won't open back up. Now, then of course, either way, whether you have water that's blocking air or just the fact that you're not getting any new air in, you're going to have the effects of accumulation of carbon dioxide, which leads to what in the body? Acidosis. And then which leads to respiratory and cardiac arrest from tissue hypoxia, from acidosis. All right? The male sex. Hey, y'all, watch this. I'm going to hold my beer and I'm going to go jump off in the middle of this lake with all these sharks. Younger than 20 years old. Younger children. All right? Ineffective safety barriers. Children are very curious, right? Mom and Daddy lets us go swimming all the time. I want to go swimming now. Mama's busy. Let me go swimming, right? So obviously when the body goes under, its natural response is to hold its breath. And there's several things that factor into how long someone can hold their breath. If it's a prolonged submersion, it doesn't matter if you're the top athlete in the world. You can't hold your breath for long enough to where it's not going to start affecting you. All right? State of health and fitness, level of panic. I'm going to be panicking. I'm going to be freaking out. That's like one of those things. That and being trapped on elevators are things that keep me up at night. Drowning. Level of panic, I just said that. Water temperature. Why is water temperature a factor? The mammalian. Yeah. So cold water causes the mammalian diving reflex, and cold water, cold slows metabolism down. So the organs, the body, the brain is not requiring as much, it's not demanding as much oxygen, it's not demanding as much metabolism. So that's why you can have these children that are submerged under a frozen pond for an hour and they can be resuscitated. It's the same principle as the therapeutic hypothermia that we do in the hospital. We slow metabolism down so it doesn't lead to brain damage, and so they don't require as much oxygen. All right, so that is one of the big principles behind they're not dead until they're warm and dead. All right.
Do that just using like cold fluids.
Mm-hmm.
Just put cold fluids in. Is that how y'all do that? I see.
No, there's actually a machine that it straps on their thighs and it straps on their flank, their stomach, their flank, and their back that has cold water that has these cells that are made out of gel up underneath them, and it runs cold water all through those pads, and so we adjust and increase and decrease the temperature of the water, and so that's what actually brings the temperature down. Our resuscitation technique is the same, except remember it just says defibrillate once. Well, I guess that was hypothermia. Reaching the victim. I ain't a good swimmer. I'm not going to just try to jump in and just swim after somebody because I'm not going to do them a lick of good. All right? You need to be trained in that to try to reach the victim. All right? I'm not saying I wouldn't. Worst case scenario, hope it doesn't happen. Worst case scenario, if they're just floating there and they're not trying to fight, I might try to go out and get them. But the bottom line is you don't want to create another victim with yourself, right? So trained people, there are folks that are trained to get to them. When should rescue breathing start? Immediately. If you're out in the water, you should try to start rescue breathing as soon as you get them up. Most of these patients, once they start receiving rescue breathing, they're going to vomit. Why? Their tummies are full of water, and we're doing what? Pushing more air down is going to cause more pressure. All right? Remove vomit as you would any other way. And then it also says to maintain some positive pressure at the end of exhalation, because that's going to help keep those alveoli open. All right? So they've probably got some degree of atelectasis occurring now because their lungs were full of water, right? So we want to try to keep that alveoli open. How would you maintain some degree of heat while you're bagging them? All right, you cannot, if your bag doesn't have a PEEP valve, you can just, not completely deflate it. But a lot of ambu bags have PEEP valves on them, all right? If you put an ET tube in, go on and put an NG tube in to decompress the stomach, get the air and water out of the stomach. All right? ALS measures, pulseless, IV access, epi. Biggest thing, don't give up on the submersion patient until it can be completely confirmed that we've got the core temperature back up. Of course, there's a couple of things that we're going to look at as well. These patients that have, last time we saw him was 3 days ago, and he was underwater. We get them, we find them, and they're all bloated and decaying. Of course, we're not going to work those, right? And I already talked about the hypothermia and how it protects the brain. With your drowning, several comorbidities, just things that affect the body's response. Why they drowned. Were they hypoglycemic and they went up underwater? Did they have a traumatic accident? Those kind of things. Then your major predictors, the length of submersion, the response to the field resuscitation. Did you get something back in the field? And if they're awake up upon hospital arrival, there's likely a better outcome. And then, of course, a lot of your other post-resuscitation things as well. It's not considered a true save unless what?
They come out like they were before.
Yeah. So So you can get somebody back, get a rhythm back, but you may not ever get them back. All right. So those are some things you got to consider. Now, with drowning, there is a secondary drowning as well. All right. So just because you pull somebody out of the water, there was actually a news article a couple of days ago or last week. I don't know if y'all saw it, about a kid that actually started having drowning symptoms about 4 or 5 hours later after he had been submerged and they got him out of the water and all that. All right. So those patients need to be seen about in the hospital because there is a degree of damage that can be done to the lungs. All right. All right. So I know that we're moving quickly, and I know that there's a lot of information that we may not be covering. So again, you need to be keeping up in the book or reading the material. All right, for the test. A lot of this stuff you've covered in EMT and advanced EMT. All right. A couple of things that we want to hit on with diving injuries. Different types of diving. So with your diving injuries, most often your injuries are a direct result of the pressures. All right, the pressures, the atmospheric pressures versus the pressures under seawater or sea level. Your pressure is the force per unit of area. We look at it at weight of air at sea level when we're talking about diving emergencies. ATA, the abbreviation ATA is air at sea level. No, that ain't right. Yeah, that's it. That's the one you were trying to say. Then your FSW is feet of seawater. All right, so when you're reading your book, it'll talk about your ATA and your feet of seawater, and the further you go down, how the pressure increases. At sea level, pressure is 1. At 33 feet of seawater, 33 feet down, your pressure goes up, and so on and so forth. The majority of your scuba diving is at depths of 60 to 120 feet, so it is a substantial amount of pressure from sea level. All right. So there are things that commercial divers would do, all right, and then trained divers would do for those really deep dives, and that's going to be stop-off points to let their bodies adjust. There's a couple of laws that we talked about, but this is where these laws are going to come into effect, and it all has to do with the way that the body, or it all has to do with the way gases and liquids react to pressure. So liquid volume does not change with pressure, but gas volume does. All right? So that's going to be something important to put in the back of your mind. So your body tissues are not, are primarily water, so they're not as affected as much, but then the gases in the body are what affects the body whenever you start having these pressure changes. All right, so you've got Boyle's law, and then Boyle's law says at a constant temperature, the volume of gas is inversely proportional to its pressure. So basically what it says is that as the pressure goes up, the volume of gas is reduced. And as pressure goes down, the volume of gas is increased. All right? So, for instance, as you decline further into the depths, what happens to the pressure? It increases, right? What happens to the volume of gas? It decreases. What gases do you think we're looking at? Nitrogen's a primary one. All right? So, Boyle's law is a law that explains barotrauma, especially to organs that are filled with gas. Barotrauma, trauma related to pressure. All right? For instance, you've got a hollow organ that's full of air. You start going down, the pressure of the gas, pressure of the air is going to decrease, so it's not going to affect it. But then you come back up quicker, the pressure starts to decrease, the air starts building up, and so it's going to cause trauma because the pressure is increasing faster than the body is used to. Does that make sense? The effect of this is most extreme near the surface because you're going to have a lower amount of pressure, which means you're going to have a higher amount of gas. Okay? So Dalton's law. Each gas in the mixture exerts the same partial pressure it would exert if it were alone in the same volume. So what it's saying is that the partial pressures of all these gases together individually would be the same partial pressure if nitrogen was by itself, or if oxygen was by itself, or if the other ones were by itself. So the total pressure of the gas is the sum of the partial pressures of all the gases in the mixture. So to get the partial pressure of the gases in the mixture, you've got to add the PO2, the PCO2, and the nitrogen, the partial pressure of nitrogen. That's where you get your atmospheric pressure, all right? The atmospheric pressure that's exerted right now is the sum of all these individual gas partial pressures together. When the total pressure goes up, the partial pressures go up proportionally, all right? This is the law that explains nitrogen narcosis. We'll get into nitrogen narcosis in just a few minutes. But basically what that means is as the pressure goes up, as somebody goes deeper and deeper and deeper, it's going to make the partial pressure of nitrogen go up. So there's going to be a higher partial pressure of nitrogen, so it's going to exert itself more into the body. So the partial pressures is going to make the nitrogen get into the bloodstream, and it's going to make it get into the nervous system. All right. So nitrogen narcosis is when the brain gets full of nitrogen, and nitrogen in large amounts has an anesthetic effect on the body. All right. So they get very confused in the really deep depths. They get very confused, alter mental status, things like that. And then Henry's law is the amount of gas dissolved in a liquid is directly proportional to the partial pressure of the gas above the liquid. This explains the bends, or the decompression sickness. All right, we always hear about the bends. That's the primary one you ever hear about, and that's where your nitrogen bubbles get into joints and things like that. It can be caused embolisms. So commercial divers, they use a decompression schedule. All right, commercial divers, they're going to be the ones that are going really, really, really deep. So they're going to have to actually come up and decompress at different areas before they can make the surface. All right, that keeps them from getting the bends. That keeps them from getting these different gas diseases or gas illnesses. And then sometimes they will even have nitrox gas, that might be what they're breathing, which decreases the risk of nitrogen narcosis. So a couple things you need to ask if you have diving emergencies. When did the symptoms start? Did they start after you surfaced, or did you actually start feeling this way while you're diving? What type of diving equipment, the type of tank, probably wouldn't mean a whole lot to me. I don't know much about scuba diving. But they could probably explain to you. The diving site and the water temperature. Number of dives in the last 72 hours, because that pressure could accumulate and build up. Different safety mechanisms, dive computers that were keeping track of everything. Did you use safety stops? In-water decompression, things like that. So nitrogen narcosis, what we talked about just a minute ago. Altered mental status from breathing compressed nitrogen containing air at depth. All right. So again, the pressure is building up. It's increasing the partial pressure of nitrogen. It's compressing that nitrogen. That nitrogen is getting forced into the body cells. All right. You know, following me? You see the signs and symptoms.
Did you get us from flying too? Same day you died?
Do what? You can. Because of the different pressures, I guess, right? So a lot of the things that you see here, the signs and symptoms, we've talked about it, mental status issues. So they need a controlled ascent to manage this. Again, we talked about the nitrox gas that they may breathe. Then barotrauma, we talked about this just a minute ago, a pressure imbalance in the gas-filled spaces in the body. It can affect any gas-filled space in the body. If they come up, they ascend too quickly, that pressure may increase quicker and it may cause barotrauma. A lot of times your pressures affect inner ear stuff. I mean, even if you've got like an inner ear infection or something, you can feel the pressures. So that's going to be something that'll be affected big time. And of course, when you have that with inner ear stuff, then you also it exerts effects of like vertigo and things like that, which is going to alter your perception anyways. All right. So your treatment for barotrauma, everything you see there. You want to catch any blood or fluid from the ears. Antiemetics, especially if they are experiencing vertigo type symptoms. And then symptoms from decompression is hearing loss and vertigo, like we talked about. POTS, pulmonary overpressurization syndrome. If they fail to exhale during ascent, what's going to happen to the pressure inside? It's going to increase because of which law? Boyle's law, right? So obviously, lungs are filled with gas. The gas pressure builds up. What's going to happen to the lung tissue? It's going to pop. It's going to rupture. All right? They may have the subcutaneous air above the clavicles, also known as what? Subcu emphysema. May have this Hayman's crunch, crunching noise synchronous with heartbeat because of the air that's been forced in that area. 100% oxygen. Arterial gas embolism. So this is going to be air bubbles from the ruptured alveoli enter the pulmonary capillaries. Gives you a pulmonary embolism. Travels to the left side of the heart, then it pushes off into the rest of the body. So it's not a pulmonary embolism, it sends an embolism to somewhere else in the body. Could involve cerebral functions if it makes it to the brain. Uncontrolled ascent is a big one with this, but it can occur in shallow water. So what is going to be the bottom line treatment for most of these? Oxygen for us, and then they need to go to what? Hyperbaric chambers. Alright? Right next to ETS. Building right next door to it. Have all y'all seen a hyperbaric chamber before? Yeah, they all look about the same. Yeah, because that is one. Alright? So again, our treatment, 100% supplemental oxygen. Trying to get their oxygen content up. Normal saline. Decompression sickness. Also affectionately known as the bends. Alright? So nitrogen bubbles in the blood and tissues come out of the blood solution during the ascent. Gets into the tissues, interferes with tissue perfusion, can get into the joints, causes a lot of pain. It's not the same process per se, but it's kind of the same idea. If you've ever had laparoscopic surgery and they feel your belly, and then a couple of days later your arms start hurting real bad in the joints. Any of y'all ever experienced that? I did whenever I had my gallbladder out, and the doctor told me it's because the nitrogen that they used to help expand my lung or my stomach that was in that mixture actually got up into my joints and all that, and it just had to work itself out. All right. So in this case, the nitrogen and oxygen are carried to the tissues, and the oxygen is metabolized, but the nitrogen still just hangs out, which again will interfere with metabolism. And this says that if they got a foramen ovale, patent foramen ovale, you remember what that was? Usually occurs with kids, and it usually closes up.
Oh,
Yeah.
The barrier between mold.
I think so. Yeah. Where in development, it bypasses the chambers and all that, and it usually closes up. So anyways, I guess the nitrogen bubbles can get in pulmonary circulation. All right. So a couple of types of decompression sickness. You got type 1, which is your mild form, and then your type 2, which affects the big-time organs. All right. This is supposed to be musculoskeletal system. This point got up here. All right. Again, for us, 100% oxygen. Need to try to get them as much oxygen as possible. And you got a hyperbaric chamber to have this pressurized out of, right? And the hyperbaric chamber is going to all affect the partial pressures of these different gases to help force them out of the body, all right? So your hyperbaric oxygen therapy is indicated in patients with arterial gas embolism, decompression sickness, carbon monoxide poisoning, some of the other things you see here. So it mechanically reduces the bubble size, reduces nitrogen content, increases oxygen delivery to ischemic tissue. It's really the only way that they can get full treatment if it is severe decompression illness. So here's some of your risk, and then some of the care recommendations that you need to look out for. We're not going to really have a whole lot of dealings with a hyperbaric chamber. Just know that these patients need to go to a hyperbaric chamber. All right. Other gas-related problems. They have gas mixtures. The divers do, and some of y'all may be divers in here and probably can explain this a lot better than I can. But if the mixture's not right, if they have less nitrogen, they're likely to develop decompression sickness, and then more oxygen, they're more prone to oxygen toxicity, all right, which would be a central nervous system emergency. If you have underwater seizures, which could be a effect of that, then the person hopefully is going to be on like a tethered line or something. They're going to have a controlled ascent above, I would assume. All right. The shallow water blackout. This is frequently seen in teenage boys competing to remain the longest underwater. Them crazy boys. So they try to hold their breath a long time, and then they end up passing out because they are going to definitely win. So I guess the effects of this is that they hyperventilate just before going under to extend the endurance to get the oxygen levels up, but the carbon dioxide level is low, and so the respiratory drive is depressed, so that helps them, but then it also affects metabolism in the body. Once they go up, their oxygen plummets, then they black out. All right. So here's a number that you can call. If y'all want to put it in your phone, I've never had to call Dan. All right. You need a break? No, not too terribly long. All right. Let's just get on into altitude illnesses. So we looked at diving illnesses, and that's going to be because of the pressure exerted below sea level. Altitude illness is going to be pressure exerted above sea level, all right, and issues with that. altitude illness, the problem is that you've got low partial pressure of oxygen. So the air is thinner, the oxygen is thinner, you don't have as much force exerted, so you're having to use more oxygen than if you were at atmospheric level. Because the oxygen, the partial pressure is not exerting itself, so it's not as easily absorbed into the body. Does that make sense? And so that's going to be an effect of Dalton's law. So you've got acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. Typically occurs rapidly ascending to above 8,000 feet, can be 6,500 feet. Body adjusts by defending the amount of oxygen available for delivery to the tissues. And some of your symptoms are going to be the same as if they were hypoxic. The kidneys will secrete bicarbonate in the urine, and because of the loss of bicarbonate, then they're going to start experiencing metabolic acidosis as well. So hypoxia is your main problem. HAPE results from marked vasospasm of the pulmonary arteries, which again is going to limit the amount of oxygen that's being delivered to the body. So I'm assuming that, for some of these big areas, they may carry portable hyperbaric chambers with them. I don't know. Anyways, it's a bag that pressurized air is pumped in. Anybody know anything about a portable hyperbaric chamber? Lightning strikes. Lightning strikes, leading cause of environmental death in the U.S. causes 50 to 300 deaths a year. The problem is it's just straight current, straight voltage. It's not alternating or direct. It's just straight millions of volts hitting. And lightning's looking for a way out. So usually there's an entry and an exit. The energy goes all over the victim, and as a result, what's going to happen? Huh? What? Alright, so it could massively depolarize the heart all at one time, right? So it's like defibrillating somebody, but at a much higher voltage, which can really screw up the heart.
Can it also have a heartbeat, even if just doesn't respiratory training?
I guess.
Can we learn something about that? Want to made it up?
I don't know. May have. Well, yep, you're right. Lightning bolt's energy may act as a giant depolarizing charge to the entire body, can cause asystole and or respiratory arrest via diaphragm depolarization and brainstem-induced central apnea.
Look at that.
There you go. Y'all need to listen to this kid. So with lightning strikes, oftentimes it'll affect groups of people, that are standing under trees or whatever. So you use reverse triage. You attend to those who appear dead first, because the strike induces cardiac and respiratory arrest, so they don't really have time for you to wait. And in this case, you would work them first, because if the other people are walking around, they're obviously not going into cardiac arrest at this moment. All right? Envenomation, bites and stings. Y'all talked about this in toxicology, right? Fire ants,
Yes.
snakes, scorpions, and all that. Alright? So, y'all talked about Hymenoptera, stings by yellow jackets, wasp hornets, fire ants, honeybees. So, the melittin is a protein that causes the immediate pain, but most often it's a result, your symptoms are a result of anaphylaxis. If anaphylaxis or allergic reaction doesn't occur, you don't really have to worry about transporting them. They've just got a sting and they should be alright. Alright? Snake bites. see the two snake families that are concerned. Your pit vipers and your coral snakes, they have the enzymes and the neurotoxins that are going to cause the problem. All right. So, just going to move on through this. Spider bite. Ours that we worry about is the black widow, the brown recluse, and the hobo spider. The hobo spider, found in the northwest, clinically similar to a brown recluse, is a little more aggressive. All right. Black widow is one of the most venomous of the North American spiders, and them little mofos are everywhere at my house. Causes me panic attacks frequently. Do what? All right. So y'all talked about treatments of spider bites and all that in toxicology. Yes? Yes? No? Yes? No?
Yes.
All right. Scorpion stings. The bark scorpion is the only one that's a potential threat to humans. I don't think they're around us a whole lot. I've been stung by a scorpion. Yeah, I'm that guy. It hurt. Made me freak out because I didn't know that it wasn't going to kill me, but it hurt. Probably it felt like a bee sting. All right.
Is that like the only scorpion period, or is that the only one in the United States?
It's the only one that's going to cause injury to us in the United States. I think there's some pretty bad deals everywhere else. All right. Scorpion stings. Most of your treatment is going to be in hospital. Tick bites. Of concern: Lyme disease and Rocky Mountain spotted fever. Remove ticks. Grab the head as close to the skin as possible. I've even heard like bee stings and stuff. Use a credit card and try to scrape it off. All right. If you grab a tick too far back, you're going to leave the head embedded into the skin. All right. Anybody got any questions?